I open this academic ceremony in which Elena Brachtel will defend the academic thesis, Smaller, Faster, Brighter, New Concepts in the Tissue Diagnosis of Breast Cancer. May I invite you to present a summary of your study and the conclusions of your thesis?
Unmute, Elena.
Hello, good morning, America, and good afternoon in Europe. Dear Pro-Rector, highly esteemed opponents, dear committee, dear ladies and gentlemen, dear colleagues, friends, and family, I would like to present you an outline of my thesis with the name Smaller, Faster, Brighter. This is about the new concepts or contemporary concepts in the tissue diagnosis of breast cancer. And just to structure my talk, first there is an overview of what is breast cancer. Then the part A consists of advanced breast cancer diagnostics on limited, so small tissue biopsies and cytology. Then part B is about novel interfaces between imaging and pathology. Then I will conclude with a summary and a discussion. So to give you an overview, breast cancer is a persistent threat, mostly to women. About 1 in 7 to 1 in 8 women gets diagnosed in her lifetime with breast cancer. The survival is improved, is very good. More than 95% have a 5-year survival if they have stage 1, that is a localized disease with a relatively small tumor. However, as the stage gets higher, the survival gets less, so that metastatic breast cancer has a much reduced survival. We do, as pathologists, distinguish different types, grades, and sizes, and early and precise diagnosis is very important. Here, a pictogram of what it is. Stage 0 is an intraductal carcinoma that is confined within the milk ducts. Stage 1 is a small tumor, less than 2 centimeters. Stage 2 is kind of in the middle with already some lymph nodes under the arm affected. Stage 3 is then a larger tumor, and stage 4 means you see that here there are other organs already affected. There's distant seeding. Now, how do we diagnose a breast problem? This can be a noticeable lump that is found by the patient herself or her practitioner, or something only seen on breast imaging. And in many countries, including the Netherlands, the US, Germany, and others, there is mammographic screening for women of a certain age. And there can be things found, a nodule that is not noticeable to the woman herself, but a nodule on a mammogram, on an ultrasound, a cyst or calcifications, enhancements, architectural distortions. That means something doesn't quite sit right with the tissue, or other things. And then how do we diagnose? We need at least some cells. And here at the bottom is a fine needle aspiration sample. These are cancerous cells that were aspirated through a very thin needle. This is what we at least need to make a diagnosis. And then core biopsy is a tissue cylinder of several millimeters across, and in the end, it gets excised. Here is a tissue piece in the range of centimeters. This is when the cancer is removed and with a rim of normal tissue around it. So how do we go about this to diagnose unlimited samples? Well, everything is getting smaller. This was in the 80s, the modern version of a cell phone, of a mobile phone. It was huge. And now everything kind of gets smaller. And the same is true for tissue samples. While the definitive diagnosis is tissue-based, the amount of tissue is quite variable and also gets smaller. So we do more with less, similarly to those devices that get smaller. This is a study I was part in with testing a molecular identifier. This is setting the stage for cancer more or less in general here. We had a parental cohort with more than 1,000 large specimens, and then we looked at, does this molecular identifier based on 92 genes with a commercial partner that we work with, does this also work for small samples? And so we took a range of specimens and we tested it, and we actually saw that 91% likelihood to make the correct diagnosis also on these small samples that we've referred to as sensitivity. So fine needle aspiration 100%, and then core biopsies and these small tissues. Looking at the breast specifically, these cell samples, cytology, this was for a long time the standard of care for a pre-operative diagnosis. Many centers in the US and in other Western countries have replaced it by core biopsy. But in some centers, we still do it, or in Maastricht, we still do it. And also in many lower resource settings. And this is, for example, a rural hospital or in a developing country where there's not really any, a lot of imaging setup. This study I'm presenting also in my book is a cytology study performed at Mass General. We looked at in a retrospective fashion at a large number of samples. And we compared it with subsequent histology diagnosis, clinical follow-up, and especially because we had a pathologist-run FNA clinic with a fine needle aspiration clinic, and we did the aspirations as pathologists and had control over the tissue sampled. We could also include about 300 cell blocks, so cancer cases, and we compared the outcome. This is an overview. Most of these samples were actually benign, and about 16% malignant here in the purple pie. And of those, we did a HER2 testing. This is a targeted, the aim of a targeted treatment for patients, and we found that the here the kappa value, so what really was then repeated in the subsequent excision on the large tissue sample matched very well what we did in the in our little samples. And also to segue, this is a literature overview, a meta-analysis to prepare for the updated breast cytology Yokohama system, an overview of papers where we really looked what risk of malignancy is associated with a certain category of diagnosis, and with the goal to really check with the literature and attach a risk of malignancy to a cytology diagnosis. And you see here that malignant is also is very high with 90 or 99%. To segue, so we made a diagnosis, a patient gets operated on and tissue is removed to remove the cancer. And now we as pathologists, we are curious to see what is in the tissue, and maybe even before we cut into, because before we analyze it. And I have several techniques that are outlined in the book here, in the book of my thesis. That one is I will not go into much detail here, a study of micro CT of breast specimens that we looked at, and also one with a new confocal microscopy technique. Here I want to bring your attention to something that is quite new. This comes from an optical engineering laboratory. Is called laser speckled rheological microscopy. And to give you an idea what this is, here's a laser, and here are the speckles on the right side. So we have a microscope, and it basically measures the elasticity of a tissue. And this tissue is here on the stage, so we can look into this tissue. These are different time points, and the basic idea behind this is that cancer tissue gets stiffer, and there is a different composition of the matrix of this fibrous background that cancer cells elicit, and this can be measured. This is not a microscopic image, but we correlated this in the study with 150 patients, and we looked tightly at the histology. This is what you see here in this pink and blue purple color. These are the hematoxylin and eosin traditional histology slides, and here is the laser speckle. Here is a collagen stain, and here are what is in the paper described as a shear modulus, and here in this second column as the gradient. And you see that the cancer cells that are dark blue here in the hematoxylin are also depicted here with the light, the bright contrast in these artificially colored laser speckle microscopy images. And we went through a large number and correlated one by one the images with the histology, which histology in this setting is the gold standard. And another technique where we don't know yet if this all is going to work, but I want to just show it. And another technique is looking at tissue also before it is sectioned or processed, and this is now already in the operating room. And here is working with a fluorescent agent that is actually injected into the patient, into the bloodstream a couple of hours before the operation. The idea is that it enriches at the sites of tumor. And then there is this workstation in the operating room. Here is a handheld device that is covered with a sterile probe cover, and the surgeon can shine a light at the wound, basically, where, let's say, a lump was taken out, and they want to just see if there is residual cancer left. And then there's a computer system to make all this visible on the screen. And what we did here is also with several preliminary studies, just a proof of concept. Does this actually work? Can this be done? And here we have these computed images, either in a bright white ex vivo, that means out of the tissue is already out of the patient, or colored, lighting up here in red. And what we found is that, yes, we can correlate this with exactly the tissue pieces that were then processed histologically. And we could even match the shapes here often. And this is an invasive ductal carcinoma here in bright red. Here's an invasive lobular. So various types. And that was the work also together with engineers who were working on the technical aspects, and I'm on the pathology end of things. So to summarize, my task was to show that we're making the most of small tissue samples for diagnosis of breast cancer. I also want to show that there's a continued role of breast cytology in both high and low resource medical settings. then I want to show that new imaging techniques allow a glimpse into tissue right after it is taken out of the patient. And there's also clinical research going on with technology to allow looking into tissue right before it is taken out. And time will tell which of these techniques and also new technologies will then be practical, fast, and useful. I thank you very much for your attention, and I'm ready to take questions. Thank you.
Thank you very much for this very clear presentation. The opposition will be opened by Professor Manon van Engeland. She's professor of she's a professor of pathobiology of cancer at Maastricht University. Professor van Engeland.
Thank you, Mr. Prorector. Dear candidates, with great pleasure, I have read your thesis, and your title is quite challenging. It says smaller, faster, and brighter, yes, written with a colon. If you would have to choose now between replacing that colon with either a question mark or an exclamation mark, which one would you choose and why?
Thank you. Highly esteemed opponent, for your question. It would depend on the time of the day. So I do think a question mark is also very appropriate. We don't know if we are really getting any faster, or if we in many instances is faster is also better, because we have to, with our diagnosis, we have to be right, and within a certain time frame we have to take the time, and so a super fast might not be in the interest of the patient either. I think smaller is a reality. We already do this, and we do extract from minimal samples a maximum amount of information, molecular information, diagnostic information, and brighter. This is aspirational. So thank you.
This was exactly what I wanted to discuss with you, because in your summary on page 111, and now I quote, you say, practice and marketplace will tell which of those techniques will prove useful in clinical practice in the long run. And you already mentioned, we don't know what technology will make it into clinical practice, but do you really think we should leave it to practice and marketplace, or to time, as you refer to in proposition 8?
I'm being realistic here. There is a marketplace, and we also need to, of course, I do not, by the way, have any conflicts of interest here. There is commercial partnering, and some of the technology is intellectually very attractive, but it just doesn't pan out. Is somehow not practical to do, and other technology is being picked up and is very successful. So I just gave an example of this micro CT, for example. We love to work with this. We got a loan machine, and we micro CT'd basically everything what we could get our hands on, and thought it was very effective. But is this now really going to work? We have already a radiographic tabletop machine that I did not describe in my thesis that might be more practical. So this is, I really have to leave this to the future.
Yeah, I agree partly, but what should be the role of scientists or clinicians? Because what we often do, and I can blame myself for that as well, we do research, we publish a paper, and then the paper ends up in PubMed. And I personally think that there's quite some work that we can do in the follow-up of publishing these papers as scientists and as clinicians.
Yeah, I agree. I think it's important to talk about it. and to talk about it to many audiences. Two clinicians, two surgeons, we all are sitting in our bubbles sometimes, in our diagnostic bubbles or our scientific bubbles. And I think it's very important to take this technology also on the road and to say, hey, this is what we can do. And then we need to communicate with the surgeons what they actually need, what they want. And to work with engineers, I've done this over many years. We're talking different languages, so this is we need to practically engage to create ideas and to communicate them. And I think also, take it to meetings, take it to clinical meetings, take it to just to talk about this and to get ideas.
What about providing the required evidence to convince other parties? And with evidence, like validation or cost effectiveness, because that's another argument that's very important in this discussion.
Yeah, the cost effectiveness, as I say, this is a dynamic theme, because the something, and this has come up a lot with cytology, for example. There's one way of looking at this. Some say cytology is very cost effective. Others say in the whole big scheme of things, it actually is not, because there's a certain number of indeterminate results. So it depends on where we are. Also, as there is a scale of things get cheaper. So a machine gets cheaper, and that is and I think the evidence is done with correlative studies, where we really say this is what we see, this is what our current truth is, and we measure a new technology against our truth, or our gold standard, as I might say it. And these are tedious studies, but I think that's very important.
Yes. What about referring to providing evidence, performing research like you did in chapter 4? The meta-analysis, the reviews that might not be initially considered very innovative, but for translation they are extremely important.
This is also these numbers, to extract these numbers from the literature. This is sometimes it was trying to compare apples with pears, because or apples with oranges, because all the studies are so different, and it was difficult to find one consistent definition of, let's say, what is atypical. They were lumped together differently. And but I think if you can also explain to a patient, this is your sample result, and here, based on the literature, we have a risk of malignancy. This can translate, oh, this is a quarter. There's a quarter chance now that this is going to be something bad. And I think this is also this is my kind of evidence that I can provide as a pathologist.
Thank you very much, and I'll return the word to the proactor.
Thank you very much.
Thank you.
The opposition will be continued by Professor Schmidt. He is a professor of pathology at the medical faculty of the University of Porto.
Great, thank you very much. Dear candidate, dear Elena, congratulations for your work and for your presentation. That was very clear. My first question to you is that, being a faster, brighter method to diagnose breast cancer, how do you explain that breast cytology is disappearing in many parts of the world, knowing that in many centers is the only method to diagnose breast cancer? What you propose to contradict this?
Highly esteemed opponent, Professor Schmidt, thank you for your question. I'm aware of the developments. I'm aware of the papers. I'm aware that in many centers, core biopsy is considered the way to go. I do think that well, first to keep talking about it, writing about it, and doing studies. And also, I do not see, for example, here at Maastricht in this practice, there is still breast cytology being done, and it's definitely a maximum care facility. It depends also on the radiologists, how they view it, and on the clinicians, how much they trust the method. And I see it on a more or less sliding scale. When we worked with cytology, we did a lot on cell blocks. So we verified we did mini tissues, we did micro tissues, if you will, and all these are small samples, and some of the core biopsies also not much bigger than what we produced as a cell block. So I do think it's talking to clinicians in the place where I am, and it is also keeping up the studies with various there's a cell matrix matrices or samples that are just small, but core biopsies are also small. So I do kind of put these together in one category.
Do you think that could be useful to have a minimal data set for cytology also? Because in many organs, for example, for breast, you have a minimal data set for what the pathologist needs to inform in a core needle biopsy. We don't have this for cytology, right?
Yes, and I do think we should have it. So, or devise it. Yes,
Yeah.
and the clearer the criteria, the better. That is my conclusion.
Yeah, because in the questions of Professor Van Gelder, she said something that is important in my point of view concerning the cytology. It's the validation, it's the adoption of a uniform criteria, as you said. I think that this is two obstacles to widespread use of cytology in breast, because in good centers, with trained persons, works very well, as you showed.
Yes, I agree. I do not know, once a large medical center has moved away from cytology, there's also knowledge that gets lost, and so diagnostic knowledge. And I'm concerned about this. I try to, as it is in my powers, to counteract this, but yeah, I have to also leave this to give it back.
So my second question is about your three fancy technologies, advanced technologies, as you can call, especially this laser speckled rheological microscopy that looks like a bit complicated to implement in the practice. I want that you discuss if you have some information about an alternative that is to stain breast cancer tissue with old stains like Mason. And to apply artificial intelligence programs in digital pathology to study differences in the stroma. Yeah.
I think with or without stain, this is also, there are studies now with, there was one with a scanner of native tissue and a virtual coloring. There was a work out of Zurich where they basically created a virtual histology of core biopsies, and there are proof of principle studies, and it does work. The question is, how good does it work and how expensive it is, and then I'm getting to this marketplace thing. Of course, with the laser speckle, the idea is also matrix elasticity. It uses native tissue, so there is primarily nothing stained, and what I showed were the correlations that we did later on. It is a it is a complex setup. It is yes, optical engineering, but it requires computer work, but it actually was quite rewarding to see how we can look into tissue right there. And so I do think it is feasible.
Okay, thank you very much, Elena, for your answers, the Pro-Rector.
Thank you.
Thank you.
And thank you for your presence, Professor Smit, from Portugal. It's always greatly appreciated to have international opposition. And we actually move even further away from Maastricht in this online session. We move to the United States. The next opponent is Professor Pittman. She is Director of Cytopathology at the Massachusetts General Hospital in Boston. Professor Pittman.
Thank you. Congratulations on a very nice thesis and clear presentation. Dear candidate, I have a question for you regarding the fine needle aspiration biopsy process and technique. Obviously, for it to be accepted, the quality of such an FNA and if the processing of a cell block are critical to providing the tissue necessary for the ancillary studies. Do you have a recommendation for a standardized protocol for processing that would homogenize the testing of the cells obtained on FNA around the world?
Highly esteemed opponent, dear Professor Pittman, I do have a protocol in mind. This resembles closely the practice at MGH. I think there are certain things that work extremely well. One is to double check with ROSE, which is the rapid on-site evaluation by the pathologist in a pathologist performed procedure and also in a radiologist or clinician performed procedure, to just double check right there, and then to allocate tissue when if there is a place where there's only a GIMSA and air dried smears, that is a practical limitation. If there is a liquid-based cytology, that I think is good, and in my mind, to formalin fix a sediment and process it as a formalin fixed paraffin embedded tissue would then be ideal if there is a cancer and there is enough material. So to kind of stagger this according to what the resources are, I think this is very important.
And do you have a recommendation for the minimum number of cells needed to give you the DNA necessary for the ancillary testing? Say, for example, in your 92 gene testing, was there a minimum number of cells that related to that viability?
Thank you for the question. I think there are numbers that can be attached. This was about 5,000 cells and non-necrotic cells. So in a good preservation that allowed this testing. And again, this can be a core biopsy and or a subblock sample. And also it can be a fluid sample, or it can be formalin fixed paraffin embedded tissue. I think we need to be very flexible on what we use for processing and do the appropriate validations.
Yes, and I mean, I think that's one of the important points to realize on FNA is that, you know, although formalin fixed paraffin embedded tissue has been the predicate device for a lot of clinical trials and why core biopsy replaced FNA, is that you get a higher tumor fraction and tumor purity with an FNA compared to a core biopsy, and the ability to use substrates other than formalin fixed paraffin embedded tissue like direct smears does require validation, but should certainly be utilized in testing going forward, as we know it can be in pathology.
Yeah, and also thank you. I think the metastatic tumor diagnosis also for breast carcinoma is most of the time actually on cytology, because this is accessible, and it's also with radiology control, and we check if we have enough tumor cells for markers and for mutational analysis and all this. I just want to branch out briefly. There's a lot of this analysis is going on with other organ systems. With lung cancer, we do really a lot on the cytology, on the fluid in these biopsies, and we also for pancreatobiliary, where really cytology is often, because of accessibility of the organ, is the accepted standard. And I think we take breast back into this fold. That's my idea, but I'll see.
And to follow up on the utility of FNA versus core biopsy, for example, do you think the risk of metastases in the setting of core versus FNA might change the paradigm back to FNA over core?
This has been raised, the issue of core seeding.
Yes.
Yeah, and I think I keep this on the radar. I do not have a definitive answer on this. It depends again who you talk to, what opinions are, or what also essentially the bias is. Some say bigger is better, and the bigger the core, the better. I would raise doubts about this, but I also will have to leave this for the moment without a definitive answer. Thank you.
I think that does it for me. I might be a little short of my time, but I think she's answered all of my questions very well.
Thank you.
Thank you.
Good to hear. Thank you a lot. Thanks a lot, Professor Pittman. Your input is very much welcomed. Also, as a member of the assessment committee, actually all previous opponents were members of the assessment committee. The next opponent was also a member of the assessment committee, who is Professor Motaji. He is professor in nuclear medicine at Maastricht University Medical Center. Professor Motaji.
Director, thank you very much. Dear candidate, I really enjoyed reading your paper. Actually, of course, since my background is in nuclear medicine, sometimes it was difficult because it's quite far away from my expertise. However, I really liked it. I would like to congratulate you, of course, on your compilation of very nice papers in this.
Thank you.
What you might have expected, of course, is that I try to focus on something that is familiar for me. So I started looking it up. So it was micro-CT. I thought, okay, that's close to what I use in daily practice. And what I would like to know from you as a first aspect, so what makes micro-CT then, what makes it to really be in connection to your title, smaller, faster, brighter? So what is micro-CT? What roles plays micro-CT in this fact?
Highly esteemed opponent, thank you for your question. I think the micro-CT would be not necessarily brighter, also not smaller, except that it's a tabletop machine that we got as a loan at MDH, but faster definitely, because we did scans of freshly excised lumps, and the idea originally was to do this for margin evaluation. And the issue was just that the three-dimensionality of it and the fast scans that we could generate within minutes so we got the specimen, we send it through the micro-CT, but the orientation was practically very difficult to say what is now superior, anterior, posterior, lateral, and we didn't have the BB markers, so it was just challenging. And then we looked at the images and thought we had a rapid scan and then we could also do a more detailed scan. So this we had to put the margin assessment on the back burner at the time, but we made certainly experiences on the speed with which we could create a three-dimensional image of a mass lesion. Again, it wasn't good for everything. It was, for example, so there are other tabletop machines for radiographic images such as Faxitron or so for calcifications or clips, but for mass lesions, definitely this micro-CT was very handy and provided a very accurate size measure. And I want to just circle back to one of my introductory slides. There's always this question, more than 2 centimeters, less than 2 centimeters. The pathologic measurement is still considered the gold standard, and certain radiologic techniques tend to overestimate and others tend to underestimate. So this magic cutoff of between stage 2 and stage 3, excuse me, is it's important. So size matters in this.
So you mentioned calcifications and also this clip material. So this is something you would rather have an artifact on the CT, right? Or
yeah.
So what do you think you could use to also use this kind of information? Are there any options, technical options?
In terms of the micro CT, you mean? The clips and metal pieces gave us shadows, right? So this was a bit of a limitation if there was foreign material in the mass, and the sensitivity for calcifications was just not perfect. So this was probably not the right test for this. I do think with some more effort to put in the three-dimensional orientation with margin orientation, this would be very, very practical.
Yeah, you can use actually in the large cities, they have this iterative reconstruction where you can really use this kind of reconstruction to get rid of these artifacts. So that's something that might be useful.
Yeah, thank you.
But this is a post-processing step, actually.
Yeah.
I have another question. So you're talking about tomography here with CT. Did you ever heard about fluorescence-mediated tomography?
I've heard about it, but I haven't done it. So
your approach, what you're using fluorescence, is rather really a planar detection, whether on the margins you see still some signal.
Yes.
You could also use this kind of tomography to really have an idea of the distribution within the tumor and within your lump. And that might be even more precise with your size, because then you would have anatomical information on one side and plus the fluorescence information. So that was a point I was wondering whether you have heard about this. And going further is then the question about what is now the current situation, what is the future of this kind of imaging, micro-CT, with micro-CT. You think this will, every department of pathology, well, probably not, or in every OR, you should have this kind of technique to be able to be faster, or do you think this might be too much because it's only for breast cancer and other tumor entities? You mentioned earlier that there are also other tumor entities where you could use it. So what is your idea on that?
Thank you for this, for the question that I would like to give like a two-pronged answer. One was there's just curiosity, and that really it is great to have a machine like this. Will every department have one? I don't think so. Honestly, I don't think so. I do think that this this radiographic imaging in the pathology suite, and I mentioned this Faxitron technology before, which I did not include in my in my thesis. This is actually has arrived, and this is to look for clips and for calcifications, things that we can make as ourselves as pathologists more independent. They are very costly, but they are with all these neoadjuvant chemotherapy situations in breast that we're dealing with. This is probably a more direct application that will be used in pathology. Here in Maastricht, they're using it, and MGH, they're using it. So I think this is this already has arrived. And
Maybe.
micro-CT, we had to send ours back to Belgium, so we couldn't keep it.
Belgium has more money than. No, if you're talking about costly, one last question. So why are you not using ultrasound then of the lump? Because that is a quite cheap method, also quite correct with regard to size. Why are you not using this? Or it has been used actually. Yeah. But what is the advantage of CT over ultrasound?
Honestly, we had the CT, so we could. We wanted to test it. We did not. We should probably have done also ultrasound to do it in our hands. We unfortunately did not collaborate with you at the time. We just didn't. We pulled the radiologic imaging information from the clinical record, so we didn't do it ourselves.
Okay. Thanks.
But thank you. Thanks
a lot. I give the word back now to the prorector.
Thank you for your questions.
Thank you very much. And the opposition will be continued by Professor van Diest. He is Professor of Pathology at the University Medical Center of Utrecht. Welcome, and the floor is yours.
I was muted. Sorry about that. It took me a few seconds to unmute myself. So thank you very much, Mr. Rector. It's a pleasure to be here and to continue this discussion. Also, from my part, congratulations on the great thesis. I think you've made an important contribution. But there may be a few points of discussion, otherwise we would not be here today. As you said earlier, final aspiration for breast lesions is being done in Maastricht. Is that like it's still being done, or are they doing it again since you got there? Just out of curiosity.
Highly esteemed opponent, Professor van Diest. I do not think so. I would not attach my arrival to breast cytology here. It has been done, and they continue doing it as part of the repertory, essentially of what lesions they encounter. And they have a standard core biopsy protocol, but they also, with cystic lesions, with other lesions that they find difficult to access, they keep cytology in the repertory, and also for metastatic lesions with cell block, with all these ancillary tests, and then it depends on the quality of a sample, how much we can do with it.
Okay, it's just out of curiosity, because I was wondering whether they started doing it again because you kind of convinced them that this is a good idea, or you started to work in Maastricht because they are still doing breast cytology as a, I think, pretty rare exception, at least in the Netherlands, right? Okay, so we got that straight. Now, I'd like to discuss a little bit about your chapter on the final aspiration experience at the Mass General. And let me start by saying that I agree with your conclusion, right? Breast cytology works fine. But there is a but, right? I've been a fan of breast cytology for quite some time. I used to do it myself in my days at the Free University in Amsterdam, until we had this day where we had two patients in which we had diagnosed the malignancy on final aspiration, and then there was an excision done of these 2 patients, and they turned out to have a ductal carcinoma in situ.
Yeah.
From that day onwards, there was no more breast cytology, because this is one of the drawbacks. So what I would like, it's just an example, right? Breast cytology ceased to exist, and we switched completely to core biopsy. And I think this has become common practice in almost all of the Netherlands. Yeah. And perhaps that's for a reason. Now, this has my particular interest because we've, from our group, written a review on the comparison between final aspiration and core needle biopsy in the Journal of Clinical Pathology in 2012. You perhaps may have come across this paper at some point in time. And making this comparison, actually, we concluded that core needle biopsy is to be preferred over final aspiration. So let's see if we can discuss and perhaps still agree on one of these issues. If you compare sensitivity and specificity, core needle biopsy turns out overall to be slightly superior. But you will, of course, answer that it depends on experience, and at Mass General, people are very good at this. So let's forget that, all right? And perhaps say that for palpable lesions, it doesn't make a very big difference. For non-palpable lesions, it's a little bit different, I think, because the repeat rate is a lot higher and you need imaging. And that also takes away the advantage of being a low-cost technique, right? So I think at least for non-palpable lesions, I think core needle biopsy is to be preferred, or do you disagree here?
Thank you for your question and opening this up. The non-palpable lesions, there are certain centers. You're familiar with Philippe Viel's work of a one-step clinic in France. There are also places in Italy. There are places where they go after also non-palpable lesions together with the radiologists. But we had a primarily at MGH also. This was primarily palpable lesions that we targeted, and one direct link was that we need the clinicians' support and trust in our capabilities, and it also needs to always be correlated with the clinical information.
Yeah, I know. Sorry to interrupt, but there's a few other things to perhaps discuss.
Yeah.
I'm going to sort of give you a list of indications that where core needle biopsy is superior, right? And you can pick, in view of time, perhaps one of them to argue with me, which is typing of invasive breast cancer is better on core needle biopsy because you can pick out the ILCs and the low-grade triple negatives that should not be getting chemotherapy. On core needle biopsy, you can make a difference between fibroadenoma phyllodes tumor. You can separate DCAS from invasive cancer. You can grade DCAS and invasive cancer. More reliable Ki67, perhaps slightly better receptor stainings. Sequencing will be much easier because there's more DNA. Membrane and oncotype have not been validated on cytology. Core needle biopsies can be diagnosed very well digitally, and cytology is very difficult on digital pathology. And since we have same-day diagnostics for core needle biopsy, you can do it in 3 hours now. Also, the argument that final aspiration is very fast is sort of fading away. So please pick one and argue with me.
I would.
With a very short. Sorry, you can pick one and then I give a very short argumentation of your standpoint.
Yeah. I would like to thank you for giving me the options to pick one. I would like to talk about the typing and the receptors. I do think that it depends on the quality of the sample, and we can do this very well on a cell block material. It is not necessarily required to have a core biopsy, because a good cellular cell block can provide all the information, and it depends on the setting. I think how an institution is set up, this is their choice, but to have the option of generating this information on cytology is I think very important to.
Okay, thank you very much. So again, your conclusion stands, but I think the second half of the conclusion should have been, but in institutes where you have access to core needle biopsy, that is yet to be preferred. So perhaps fine needle aspiration cytology is very suitable for low-income countries. Thank you very much. I think the director wants the word back.
Thank you, Professor Diest.
Thank you. And the opposition will be continued by Dr. Carmen Severens-Rijvers. She's a postdoctoral researcher in pathology at Maastricht University.
Yes, thank you, Professor. So, dear candidates, first of all, I would like to congratulate you and your team for your hard work on this thesis. I really enjoyed reading it, and I particularly liked the title of your thesis. And it was very interesting to follow your discussion with Professor van Engeland. But I was under the impression that brighter might stand for your fluorescence techniques that you use, like for the fish, HER2, and the fluorescent imaging. Okay, so my first question is a question about statement number 9.
Yeah.
Which is, well, would you like to read it out loud?
It's where did I find it? Just hold on. You mean of the Stellingen? Of
yes. Yes.
Okay. Carmen, highly esteemed opponent. The Stelling is, or the proposition is, a pathologist without a microscope is like a fish without a bicycle. This is a bit tongue-in-cheek. We are pathologists and also at a computer. So we deal with images. And while I'm very much attached to my microscope, it's like a body part, I do think that we have to also detach in our thinking that we can contribute as pathologists also on different levels, on a molecular level, on a digital level. And there are departments that are on the way to digitize and or have already arrived, like in Utrecht, I have heard. And so I do think that we have to just keep an open mind in that regard.
Yes, thank you. I agree with you. So getting digitalized, would really help us a lot, especially for consultation cases, that we can send our files across the world and have really fast answers, like in your title of the thesis. Okay, so my next question is about the different techniques that you described in your thesis regarding the margins, surgical margins assessment. So you described, the micro-CT as primarily for tumor dimensions, and then in chapter 6, the spectrally encoded confocal microscopy, and then chapter 8 with the LUM imaging system. And I was wondering, did you investigate what the effect was for cauterization artifacts during surgery?
Thank you for the question. This is I also thought about how I can explain this best to our audience, that the surgical technique in every place is very different. And there's a certain, at MGH, for example, they did relatively small lumps or lumpectomies and did these shaves, these in all dimensions. And so they took more tissue there, and some surgeons used cautery and others did not. So it is really some do it, some don't, and we have to deal with the tissue they are sending us. For the Lumicell or this fluorescent agent, it did not seem to have made a big difference. Cautery makes the margin evaluation harder. And in Maastricht, for example, I noticed that they don't do these shaved margins, so they take generally larger lumpectomies, and thus the surgical technique is definitely different. And I can't compare this directly, but they what they did with this Lumicell probe or this fluorescent probe, they were just taking this and looking around, and didn't see any residual image in 2 dimensions, then they would record it as such. This was still part of a clinical trial, of course. Yeah. Thank you for your question. Mm-hmm.
And as a follow-up, did you perform any sub-analysis for invasive lobular carcinoma? Because those margins tend to be ill-defined.
Yeah, we had invasive lobular carcinomas. We didn't exclude them, and they were part of our study, and they also showed up. They tend to be morphologically quite sneaky and often difficult to diagnose, but we just we didn't do a subgroup analysis. The case numbers were just not allowing this to be meaningful at that point with 40 patients, and 500 in the fluorescent study, 570 margins. So there were several lobular carcinomas among them, but they were not good enough for a subgroup. So thank you.
Thank you.
Thank you.
Elena Brachtel.
Mm-hmm.
The time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return.
Thank you.
Elena Brachtel, the degree committee here present online has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Zulhausen is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Rector, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here, present online, I hereby confer upon you, Elena Frauke Brachtel, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor affixed with the official seal of the university shown by the beadle. Congratulations. We will have a few words.
Thank you. Thank you.
And actually, I hand over the first words to Dr. Scroy. Start with the laudation. Dr. Scroy, may I give you the word?
Sure. Thank you very much, Dr. Brachtel. Elena, congratulations on your outstanding contributions to the field of cytology, pathology, and breast pathology in particular. Your translational work has had impact and will continue to have impact, and I'm very confident that your future translational research will do the same. It's been quite an honor and privilege to be your mentor over the past 15 or 16 years, and again, congratulations for a job well done, and I look forward to continuing to follow you along. Now that I've been released, so to speak, you can be my mentor. Congratulations.
Thank you. Thank you, Professor Scroy. Dennis, I may say thank you so much for all these years with great collaboration. Super and supervision. Thank you.
It's well deserved.
Dr. Brachtel, let me just put some words from the Maastricht side, because it was a short intermezzo here. And we first met in 2019 at the USCEP annual meeting at the National Harbor in 2019. I think it was somewhere in a bar at a meeting of the Philips Digital Pathology. And it took me actually 1 or 2 beers to realize that you gave me the wrong name, because your name wasn't Elena Brachtel, but Elena Brachtel. So I thought it was very, very nice to see. And it was a very nice coincidence, because at that time point, I went to the USCEP to see whether we could find someone to fill in a position, which you then filled in actually only a few months later, actually in the beginning of 2020. However, you came at a very difficult moment of time, because this was just also the beginning of COVID. Of course, you started learning the language with a great enthusiasm, and you're really into this language, and congratulations also with this, because I think you learn a lot about the culture and tradition of a country by learning the language. And I think this is very important. And unfortunately, lots of the cultural things you missed because due to COVID, because all the social life crashed and everything else. And also you were affected by this. And so it was a very difficult time for you. And I'm really impressed how you managed your way, keep on working and finding the path here in Maastricht. And of course, you are a dedicated surgical pathologist. You have an independent clinical research, translational research track record. And so it was no wonder that the former dean actually forced you to commit to this PhD procedure, which of course you did very well, and also with the procedure today. So You managed to struggle through all the European and Dutch regulations which are necessary in order to be here as a doctor or as a medical specialist. And actually we paved the way for you, and actually you did it yourself, in order to promote your academic career here in Maastricht. Unfortunately, somebody else was faster in order to achieve your academic ambitions, and so unfortunately you will leave us very soon for a higher ranking position at Thomas Jefferson. So thank you very much for spending the time with us. We've learned a lot, and thank you very much for all the input you gave. It was a very good presentation. I wish you all the best for your future, and I'm very much looking forward to collaborating with you in the future. All the best to you. Sincere congratulations.
Thank you for those kind words. Thank you so much, Professor Hausen, Axel. Highly esteemed opponents, dear Pro-Rector, dear committee, thank you.
Dear Dr. Brachtel.
Yeah.
Yes, that's your official title as of now. Also on behalf of the Board of Deans of Maastricht University, I wish to congratulate you with the honor that you have acquired today. I very much enjoyed following you during this session and seeing your professionalism and enthusiasm in having actually a very dense session in terms of information exchange. It went very nicely back and forward, so this was really nice to see. There is some time for a celebration, of course. I'm not sure about your personal surroundings over there, but we will take, as a committee, we will take a bit time online just after I close the session to congratulate you a bit further. But for now, I hereby declare this ceremony to be ended.